Madison, Wisconsin is where I hail from now. How many of you have been to Madison? Oh, a pretty good number. Well, this is not what I expected. So when I was here at Fallon and I got a call from a headhunter and they said Wisconsin, and at first I laughed, which is not a good thing to do with a headhunter, but I laughed. And then while I'm talking to the headhunter, I'm going online to see where Wisconsin is on the map because, we're not trained to look very far west, but it's really a beautiful place. And, it's a little bit funny to come and talk about healthcare from Wisconsin because we're really renowned for other things like recall elections and state Supreme Court justices strangling each other and cheese curds and things like that. But, healthcare is really quite significant in Wisconsin, and it's a very unique market, as I'll talk about. But it has its downsides. And so, no one quite told me about this, but it's beautiful at least this time of year. So, I'm sorry? September. It's about 10 months of the year. Yeah, it looks like that. So Dean Clinic, you've heard a little bit of an introduction, and you kind of get a sense of our size, but I want to put this in context because it tells you why we took the journey that we're on, and then I'll talk about why I'm here, or why I think I'm here. So I would describe Dean as a virtually integrated delivery system, and what that means is there are separate components that are working together as an integrated whole. Dean Clinic is the physician component, very much like Harvard Vanguard in its components. It's predominantly physician services, but we have a shoulder-to-shoulder partnership with SSM Healthcare, which is a hospital system based in St. Louis. And together, over the years, we've forged several joint venture relationships. The one that is most significant is Dean Health Plan. It's the largest HMO in Wisconsin. We have multiple products. We are a 4-time J.D. Power Award winner in the Midwest region. We are a 5-star health plan for the last 2 years. Quite significant accomplishments on the health plan side. But we've got other joint ventures with SSM. WITS, which is a technology company where we share all of our technology assets. SMDV, which is a rural physician network and ambulatory services center organization. And we also own and operate a PBM. So we sort of vertically moved up the supply chain, and we have over 2 million lives in a PBM as well. Troy Brennan, who many of you know from CVS Caremark, spoke at GPIN yesterday, and we're like a blip on their radar screen, but we're making progress. So we're virtually integrated because we've got these two parent organizations, Dean and SSM, and as you can imagine, one's physician, one's hospital, and as in many other markets, we don't always get along. But what I like to say is we stay together for the children. The tie that binds the integrator is primarily the health plan. And because of that level of integration, and even the dynamic tension that exists between the doctors and hospitals without one controlling the other, has really given us a degree of freedom and opportunities that others don't have. So we had the opportunity to create a vision several years ago to move forward in a new future. So let me talk about what that vision was and why we picked it. Shortly before I arrived at Dean, and it prompted my hire actually, the organization found itself in a schizophrenic place. And the primary driver of that was really mostly revenue-based. We had a foot in two canoes, so to speak. The first foot was in the value canoe. Half of our revenues came from our own health plan. And so as you can imagine, because we bear the full risk. So by the way, our health plan is not a risk bearer. They're a cost center. All of the risk completely flows to the owners, the hospital, the docs. So because we own the risk, half of our revenues were coming from a desire to focus on primary care, avoidance of hospitalizations, efficient prescribing, you know the drill. We were focused on value. We had a foot in that canoe. The problem is that our other foot was in the volume canoe. Fee-for-service Medicare, all of our other payers were paying us for fee-for-service, which obviously motivated the exact opposite. Specialty care dominance, churning out additional work and so on and so forth. And so we really were in this very weird spot where we had a choice to make. And we had three options. One was we could step into the value canoe. And that wasn't an easy thing to talk about or a decision to make, because like many other organizations that are struggling with the transition from volume to value, our concern is, well, what if our revenues plummet on the fee-for-service side? Yes, we can play to our health plan for all of our patients, but we could suffer significant revenue losses. So that was option one. Option two, we could step into the volume canoe, and we would sacrifice our health plan in all reality. So if we worked in a volume world but bearing the risk of our health plan, we probably would suffer the consequences of selling our health plan or disintegrating from our health plan or disowning the risk, which was a problematic decision as well. And the third option was we would ask our doctors to practice two types of medicine after looking at the insurance card. And we gave that a thought for about a nanosecond and dismissed it because there's no way we would do that. So we made a decision, and we made a decision out of necessity and out of desire and out of intuition and out of luck. Necessity was that we were struggling as an organization and financially failing. We had no clear direction. Desire, our doctors wanted to practice one type of medicine, and frankly, we knew what type of medicine they really wanted to practice, which was value medicine. So long ago, long before the ACA was passed, long before the ACO terminology was established, we picked the value path. And it took some intuition because our projection, and my projection still to this day, in fact, at GPIN, I'm the facilitator of something called Hot Topics. GPIN is the Group Practice Improvement Network. I asked the audience, how many of you believe that incentives and compensation in the future will be mostly value-driven in the next 10 years? And these are very high-performing systems. 95% of the people in the room raised their hands. So our intuition was we were moving toward value, and the luck part of it is that actually that is happening. So we've come to this place where we've skated to where the puck is. And so that's why I'm here. So why is this hick from Wisconsin up here talking in front of the highly distinguished, renowned Massachusetts healthcare marketplace? It's because we have lessons learned. We made a decision to pick a different path all those years ago, and it created a total shift in paradigm for us. So we've been thinking differently ever since. And our vision has been purely to deliver better care at a lower cost and let the rest of the industry focus on volume. We're going to do our thing. And so we've been doing our thing and making mistakes and learning lessons this whole time. So in true David Letterman fashion, I think the best way to share our lessons is the top 10 list. So here are the top 10 ways that we've changed, and we would project that all of you will change based upon what we've lived through over the course of the next several years. Okay, so first, let's talk about teamwork. So I was at Harvard Community Health Plan when Harvard Vanguard divorced from Harvard Pilgrim Healthcare. And then I was at Fallon Clinic when Fallon Clinic divorced from Fallon Community Health Plan. So then I was getting a bit of a complex. I thought it was me. And then I went to Dean, to this integrated system, and we weren't, not only were we not divorcing, we weren't even in therapy. So I got a sense of what the real integrated model was. And, you know, the point here is that we're fighting with each other, and we're all seeking to sacrifice the margins or the survival or the success of the other parts of the system. But the reality that we've learned is that it's the integrated system that really works best. When the hospitals, the doctors, the health plan, and the patients align around value-based care delivery, the presumption that each of us can do it without the expertise and the competencies and the skills of the other is a flawed concept. In fact, it's been interesting to watch kind of the enormous consolidation trend that's sort of reignited all over the country. And so now you've got examples of physician groups acquiring other physician groups, like the DaVita Healthcare Partners acquisition, or you've got hospitals merging with hospitals. You know, I'm sure you saw the announcement just yesterday that Trinity and Catholic Health East has announced a merger, or hospitals employing physicians and kind of sucking up the physician community as they did all those years ago. And now, interestingly, having health plans getting into the delivery business. And so one of the questions I always get asked is, who's going to win? You know, who's going to win the race? Who's going to be the most successful model that overcomes all the other models? And here's my perspective. I think that physician-directed health systems will fail. I think hospital-directed health systems that employ doctors will fail. And I think that health plans that acquire health systems and function as they had as health plans will fail. The reality is that all health systems that will thrive and succeed in the future will look alike, which is they will function as a team of equals and recognize the equal strength of talent and influence and participation of all of the players. So tool number one is teamwork. We've had some great experiences with this. We're this virtually integrated system. We've got these actually 4 or 5 separate organizations. But what we do is we develop a single strategic plan. 5 organizations with a single strategic plan. How many of you have seen that? Where we sit together multiple times a day talking about what's best for the patient and how we deliver better care at a lower cost. It's none of this, you know, bickering over whether it's the hospital system that gets the surgeries or the docs, you know, who gets the outpatient surgeries, who doesn't, or the health plans. You know, Virginia Mason is the classic example where Virginia Mason wanted to do the right thing in terms of treating back pain, and they couldn't get the health plans to really share the gain. So it became a us versus they phenomenon. And in our system, we say we're going to share and share alike. Instead of each entity trying to maximize their portion of the pie, and we just keep redividing the pie. One of my closest colleagues uses the expression, you know, when the pie shrinks, table manners change. And that's the phenomenon in our industry. So we haven't talked about redividing the pie. We've baked more pies by working together. So teamwork. So primary care. When I started, primary care was broken. We had doctors on a treadmill. They were seeing way too many visits, not safe for the patient, way too many visits, and we were losing PCPs. And I don't know what the statistics are here in Massachusetts right now, but the University of Wisconsin has not produced a general internist that has stayed in primary care internal medicine in 7 years. And all of the existing internists have moved into hospitalist medicine. And so we said, this isn't sustainable because we still believe in the primary care model. So we said, we're gonna stop this. We're gonna turn off the treadmill. We're going to implement a medical home model. And you know, one person that I talked to recently said, you know what? Why don't you just keep primary care on the treadmill? You know, let primary care generate as many visits as they want. Primary care will never break the bank for the health plan or your system, is the expression that I've heard. And I think that is just such a flawed perspective. And so we actually looked at that within our own organization. So we asked our health plan about 2 years ago, what percentage of our total cost of care goes to pay primary care physicians? So of 100% of the total cost of care, how much goes to pay primary care physicians? Any guesses? 6%. 5. All right, you guys are knowledgeable. So it was 6 within our organization, 6%. But then we asked our health plan, to what degree does primary care directly or indirectly drive the remaining 94%? What percentage do they directly or indirectly drive? Any guesses? 80%. So we said, all right, let's understand this. We have PCPs on a treadmill. Patients are coming in with 10 clinical conditions, and they're leaving with 10 specialty referrals that generates 10 hospitalizations and who knows how many lab tests and imaging tests and so on and so forth. This is ridiculous. We don't want primary care to churn it out. We want a medical home model where the PCPs are rewarded for population-based care. And so we turn the treadmill off. And we don't call it medical home. Unfortunately, I've learned I have bruises on my back still from all of my years labeling things. So I was the king of advanced access at Harvard Community Health Plan, and no one ever lost that term. So we don't call it medical home at Dean, we call it primary care redesign, because that's what it is. It's redesigning the care model. It's helping doctors do doctors' work and nurses doing nursing work and embedding mental health within the practice and forming partnerships that don't exist today. And it's stopping the treadmill-based incentives for PCPs and have them become a quarterback, not a cowboy. So that was our second lesson. Our third lesson was about data. So here we made the decision we're going to do value, and then we said, all right, let's go forth and find the waste and find the quality problems. And it was unbelievable how little information we had. We actually had a lot of data, but we didn't have a lot of information. So we started doing a lot of benchmarking. You've seen lots of versions of the Dartmouth Atlas. We started there. One of the other hats that I wear is I was recently appointed to the MedPAC Commission. And we spent a lot of time looking at graphs like this because the geographic variation is enormous. And so what we wanted to know on the Dean side was, how do we get to light green space or white space in everything that we do compared to national benchmarks? We don't want to be a dark green spot. We want to be a light green spot. Whether it's state by state or region by region, what are the best performers doing? So we looked at Milliman benchmarks and Premier benchmarks and AMGA and MGMA and GPIN and anyone that would give us data, we took it because our objective was that we were going to be best in every quality metric and every cost metric, down to the diagnosis level, to the specialty level, to everything, including overhead costs, by the way. So we looked at everything. We then took that data and we began to analyze the data looking for opportunities. So the first opportunity that we looked for was where on average as an organization were we failing versus other large buckets and averages. So that was opportunity one. Opportunity two was to say, well, where is there now variation from site to site? So we could look for more low-hanging fruit there. So we started developing, and I would imagine many of you start getting these now. We use stoplight reporting a lot. What this is a typical report card that we will give at the site level that shows quality metrics to the left, service and growth metrics in the middle, and financial metrics to the right. So everyone knows where they are. And if you're red, we encourage you to seek out those sites that are green. But we didn't stop there. We said, all right, we now need to get to the individual doctor level. So we started sharing and unblinding data. I asked GPIN about a year ago, what's the most effective tool that organizations use to change physician behavior? Unblinded data and peer pressure. And so we've done that. On the left was something that I did at Fallon. What we did, because patient satisfaction was important to us, is we measured patient sat and then rank ordered it from top to bottom and unblinded it and put it on our intranet. The yellow, by the way, is a bar that covers the names to protect the innocent. And someone had to start my car for the first few weeks after I did that because it was not popular. And, the reality is that unblinding data changed a focus on patient satisfaction so much more than incentives did. And so public unblinding of data is something that we have done, which we would imagine will become ever more prevalent. Although the other thing, and I don't think that I would have ever thought we'd get here, is we've been working with an organization called Cave Consulting. And what CAVE does is it looks at claims-based information and analyzes the practice patterns of all of our docs individually for effectiveness and efficiency and graphs them to show us which doctors are most effective and which doctors are most efficient. And in essence, we take that data, we give it to the specialty groups, we close the door and lock it, and we say, please help us understand this variation. Why do you have folks in the upper left quadrant, highly effective, highly efficient, and docs in the lower right quadrant, horribly inefficient and ineffective, all within the same department? Please help us figure that out. So I never would think that I would use the word profiling, but profiling is coming. We're doing it within our own organization, and it has significant implications. We're not necessarily tying it to incentives yet. We're essentially saying, we're looking at the data, we're studying the data. Explain this to us, but also know that we're gonna take this profiling grid, if you're a specialty, and we're gonna give it to PCPs next. So they have more transparent information on who they should be referring to. And so that's where we'll be using this next year. And then probably the year after, we will be incenting physicians based upon this information. So those of you who know Epic, Epic is in Madison. I call it the Emerald City because it's kind of in the middle of nowhere, and you turn a corner and there's like 1,000 buildings. It's great. We've used Epic a little bit differently. I've actually implemented Epic 3 times. So I implemented Epic at Harvard Community, and then I implemented it at Fallon, and now I've implemented it at Dean. And what has been remarkable, you know, I've always been a believer in technology, but we learned very early on that there was a cost of entry to technology, that we needed to implement technology. Technology is good, but that the implementation of technology is necessary but not sufficient to be a high-performing organization in the world of value. So then what came next was meaningful use, obviously. So meaningful use, we looked at the criteria for meaningful use. You know, we were like, we do all this. We 100% attested in the first year for all of our docs, all 700 providers or so, and that was good. But actually, as we looked under the covers of meaningful use, we were fascinated by it because meaningful use is also not where you want to be. It's necessary, but not sufficient to be high performing. I'll give you an example. So the meaningful use criteria says you should give after visit summaries to your patients 50% of the time. So my question was, well, what happens the other 50% of the time? And in the value world, you worry about the other 50% of the time. What happens in the other 50% of the time is patients make mistakes, or they're not adherent, or they call when they shouldn't call, or they come into urgent care, or God forbid they end up in the ER. Those are wastes. So we give after visit summaries 100% of the time. So our focus, and where I would imagine your focus will be, is optimal use of technology. Are you using your system? We've tried to move our docs away from complaining about the system and maximizing the effectiveness of it, because technology offers tremendous opportunities in the service quality and cost domain for us. And we also haven't stopped with EHR. It's amazing. Most organizations just think of EHR as the sole form of technology, but we're also investing in everything else. One of the most striking things that I learned as an internist going to business school was the degree to which healthcare doesn't use the tools and capabilities that high-performing industries use to transform themselves, and technology is one of them. So the charge to my organization was, where do other industries use technology that we should in healthcare? And the answer was just about everything: kiosks and home monitoring and telehealth and EICUs and the web. We're starting new ICUs. It's not an ICU. We're looking at e-hospitalist programs because we can't nor would we want to staff 24/7 hospitalist programs in all of our rural markets. The younger generation in particular doesn't want to come in for visits. They want to Skype with you. So are we making that available? In our world, we have degrees of freedom because we don't have the payer barriers. We can do whatever we want. And the reality is that that's exactly what the younger generation wants. They want to Skype. They don't want to come for a visit. And so, one of the trends, which I'll underscore and I'll come back to it later, is we're seeing an evolution in where services occur. Services provided in academic medical centers will move to community hospitals. Community hospitals will move to ambulatory surgery centers. Ambulatory surgery centers will move to the doctor's office. And what's in the doctor's office will go home. Or go to the office, or go, the employee's office, or some other environment. In the world of value, why would we deliver care in a setting that delivers no better quality but costs a lot more? So lesson 5, we learned that you can't pay in the form of volume in a value-based world. So here we made the decision we're going to do value. We started pursuing all these capitated contracts where a shared savings program track 2 organization would have been a pioneer. I'll talk about that in a second. And then we turned around in our own organization and said, oh wow, we're paying our doctors RVUs. And so the model at Dean was churn it out. So we were swimming upstream. So the world we ended up in is a world that I like to describe as a world of privatized gains and socialized losses. Each doctor was out for themselves. They generated as many RVUs as they could, but because most of our comp was capitated, we had to tax everyone. So the RVUs stopped at 2/3 of the way through the year, which isn't a fair model. So we went through the process of changing comp, and I think I've changed incentive comp about 10 times over the course of my career, so I've got bruises from that too. But I want to highlight a bit about how I think comp's going to change. So in our model, all the way on the left, we started with 98% RVUs and 2% incentives for patient satisfaction. Any idea what doctors do when you have a 2% incentive? They generate 2 more patients, and so that didn't really work. So we started moving toward the right, where we created a balanced scorecard of incentives for growth, efficiency, quality, service, and we started increasing them, and our ultimate objective is to take production away. And that production will still be an incentive, but equal to everything else, so that we don't make it up on volume. It's not just how much we do, it's how well we do the work that we do. So that's our specialty model, and we're almost there. We're 1 year away from finishing this. On the primary care side, we had to go a whole lot faster because we were doing medical home and we needed to turn the treadmill off. So we started in the same place, 98 and 2, and then we gave our PCPs in the medical home model 2 options. They could either stay in the volume world, but this 5% is meant to be a negative. We would cut their RVUs per unit they generate by 5%. And we would keep doing that every year that they stayed in the volume world. Sound familiar? Yes, it's the Dean version of the SGR cut. Or we gave docs the option of shifting to an incentive comp around value. Yes, it totals to 115%, because if you're generating only 5% of the total cost of care, what is another 15% on top of that? What does it bring you to? 5.75% of total cost of care. But these incentives are diminishing the total cost of care by nearly 20%. And so it's a balanced scorecard based upon panel size, service, quality, efficiency, and we're also moving in this direction. We think 60% RVUs may be too many. We probably need to come down to an equal metric along with everything else. So incentives will change by most of your payers, is our prediction. Does anyone know what this is? Sacred cows. So yes, that's our next lesson. We learned that we had to stop growing sacred cows and we had to start growing square watermelons. So square watermelons, one is India, one is Japan. In Japan, there's limited space, especially in supermarkets. Watermelons roll, and so they said, how do we think outside of the box? In this case, we'll think inside the box and grow watermelons in boxes so we can stack them. So I know it's kind of a hard thought. How do we do all the things we need to do as physicians these days? Patients want better service, better quality, lower costs, and we need to preserve and retain the satisfaction of our medical staff. How do we do all that at the same time? And the answer is innovation. So We've invested a lot in innovation. We do a lot of lean. We're not quite as prominent as ThedaCare and Virginia Mason in this space, but it's amazing to me. I sit in what's called report outs of rapid improvement events. They're week-long events. In 4 days, they take this enormous problem that has existed at Dean for like 5 years, and they put the present state on a wall, which often takes up a whole wall, and then they create a future state. And then they do rapid improvement tests to see if the future state would work, and essentially in 4.5 days, they've solved a problem that existed for many years. And it's a team-based approach. So you've got doctors and nurses and management and frontline staff and Epic people and others in the room to do this. There is a way to do it. One of our objectives at Dean is to prove to the country that the same organization can be best in the country in quality and at the same time be the lowest cost organization. So we're seeking to prove that. And the next lesson that we've learned is that quality follows. So all of our quality graphs look like this. The purple is us. So our slope is increasing in every single one. We're using lean, we're using incentives, we're using data, we're using vision, we're using unblinding of information. And in Wisconsin is the #2 quality state in the nation. We're in the high handful of top performers. I think the only organizations that are ahead of us right now are Marshfield Clinic and ThedaCare. So our objective is to be #1 in the state of Wisconsin and bring Wisconsin to the #1 state. So we've proven that these tools deliver quality, and we've proven that these tools deliver service. The left are our patient satisfaction with doctor scores. How do you do that? That's hard. No, it just requires diligence and the application of our tools. One of the things that's contributed to it, this thing on the right, so these are our scores over time. This thing on the right is a physician shadowing program. So I'm a believer that there's a formula for just about everything. And so we started shadowing all the docs that had the highest patient satisfaction scores, and we found formulas for what these docs do. And just to kind of give you a quick sense of it, the formula is that the docs that have the highest scores are the ones that engage with the patients. So yeah, the charming docs engage their patients, but not every doctor is charming. But charm was one of them. But there was more. There were some that while we have technology, they either got very good at using the technology without interrupting the patient-physician dynamic, or didn't even use the technology much in the exam room, but they concentrated on the patient. They didn't let anything disrupt them, not technology, not phone calls, not pagers. It was pure focus. In fact, one doc, you've probably all heard this study that on average, docs interrupt their patients after the first question within 12 seconds. One doc who read that study said, I ask the first question and I look at the clock, and I don't interrupt for 45 seconds. He has one of the highest patient satisfaction scores in the organization. Some docs remember something about the patient, they had a vacation, they had a puppy the last time they were in. Some docs call a subset of their patients at night and say, I was just thinking about you the rest of the day and I was worried about you and I wanted to see if you have any questions. They've become marketeers. And then one, the most miraculous of all, was I went to shadow a surgeon and he's not charming and he didn't use the technology well, and I was like, all right, my formula is flawed until the very end of the visit. So he's sitting there with the patient, and he says, so I know I've been kind of bumbly, and you may have other questions. So here's my business card, and here's my home phone number and my cell phone number. Call me anytime. And I don't know who was more surprised, me or the patient. And so I asked him, how many of your patients do you do this with? All of them. And how many have called you? 0. One of the highest satisfaction scores in the organization. So our shadowing program seeks to teach those skills plus others to our physicians, and it's the green are the doctors who've been shadowed, the red are the doctors who have not. So what does this mean for cost? Well, we've bent the cost curve. Purple is us. Red and green are the national trends. So to sum it up, we've bent the trend by 40%, while at the same time improving quality and service. So that's on our commercial population. On the Medicare population, we were a pioneer applicant of one of 53. We applied for the Pioneer program and we declined when we were invited in. And the reason we declined is we were the third lowest total cost of care in the country of all the pioneers, which is designed for high-performing systems. So to give you a sense of the power of these tools. So where does this come to roost? Well, it comes to roost because what do we believe the community will do when they face value-based organizations like we've got in Madison, there are 4 of them, and volume-based organizations like they've got in Milwaukee, which is only 75 miles east? Our total cost of care is 30% lower than Milwaukee, adjusted for demographic differences. I know everyone thinks their patients are sicker and poorer and everything else, but that's been adjusted. We're 30% lower. Are employers and patients going to pick better care at a lower cost or worse care at a higher cost? And we're playing that out right within Wisconsin. And so in an ever-increasing transparent world, which we know is happening, how will you do? Do you guys have Angie's List? So I'm driving to work a year or so ago, and I hear an Angie's List ad. Angie's List, where now you can hear reviews about your plumbers, your contractors, and now your doctors. And I almost drove off the road. I knew it was going to happen, and it did. Got into the office, the phone rings, one of our doctors who says, "Did you hear that Angie's List ad?" And I said, "Yes." He says to me, "You have to call Angie's List and tell them to stop this." And I said, there was a long pause, I'm sure, and I said, "Call Angie's List? Are you serious? What world do you live in? That's not the world that I'm in." I was struck by this Consumer Reports, and it was a special report from Massachusetts readers from Consumer Reports. I'm sure you remember it. How do your doctors compare? You know, Consumer Reports is going to take any data they've got and they're going to unblind it. And so the world that I live in is this is where healthcare is going. There's ever increasing transparency. And I gave a bunch of talks a couple months ago at Partners. And there was all the stuff about Partners, 40% costs, 40% more. And then the day before I came to visit, JACO had done a report about highest quality and highest safety hospitals, and the only Partners institution on the list was Faulkner. So I said, what happens in a transparent world? While you have a wonderful brand, and yes, there are wonderful doctors at Partners, what happens when the public sees that you cost more and your quality doesn't stand up? So we live that right now in our marketplace, and we think that's going to happen everywhere. So I've lived in all these worlds, and the name keeps changing. It was HMOs, and then it was managed care, and then it was pay for performance, and then it was patient-centered medical home, and now it's ACOs. And the next lesson we learned is that ACOs are not a payer contract. They're a delivery system objective. That, yes, we've got an important election coming up, and yes, things may change, but the things that brought us to this place haven't gone away. So our perspective, the lesson we learned is we're not going to change our strategy. I got asked a lot, what happens if the Supreme Court sort of made a different decision that they made? This was before they made the decision. And my answer was, it doesn't change our strategy one iota. We're going to deliver a better product, better care at a lower cost. That's what the consumer wants. We don't care about what the parties think. Both want better care at a lower cost. Where there's disagreement is how to get there. So we're going there. And so that's why the name doesn't matter to us. It's the objective that matters. So there's one more lesson for those who are still disbelievers at the end of my talk, and I know there are in the room, which is another prediction that we have. This is a place that some of you probably have never been to. This is Honduras. This is the Choluteca Bridge. And I use this when I need to convey to our physicians who believe that the status quo will always stay, that things will always stay the way they are. Managed care will never come, ACOs will never come, the election will change things. Things will never change. So we learned from Honduras that no, that's not the case. So the Choluteca Bridge is in Honduras. The Choluteca Bridge was the last of the 150 bridges built in Honduras, was the strongest and the most modern. And in 1998, Hurricane Mitch blew through Honduras and destroyed 149 of the 150 bridges in Honduras, but not the Choluteca Bridge. The Choluteca Bridge survived. But the bridge suffered the greatest indignity of all, which is that the river moved. Making the bridge obsolete. So if physicians think I'll never take risk, or hospitals say we're going to keep building and we're going to keep focusing on heads and beds, and if health plans think that organizations, providers are not going to try to steal risk away and create their own competing health plans, which by the way, we're helping integrated systems create their own health plan to compete with their own health plans if the health plan doesn't change incentives to share risk and gain, then the world will leave us behind, has been our experience. So the last lesson that I would convey is, as you see through the tools and techniques, you'll notice that it's about people and it's process, it's technology, it's culture, it's teamwork. It's not buildings. We keep building buildings. And the perspective of our system is our future. We're going to have 3 times the number of patients, no additional facilities, and we're going to do half as much stuff on all those patients. That's where the world is going. So keep building all your buildings and incurring all of your tremendous capital costs that you won't be able to get rid of. We're going the exact opposite way, and we're succeeding in that regard. So my last message is that this is in your hands. I'm a believer that we've always had the ability to convert and change our own organizations, even without external influences. So I hope you at least take some lessons from this and go forward and do great things. Thank you very much.